Hello, I'm Dr. Charlotte Lewis. I'm a pediatrician at the University of Washington and Seattle Children's Hospital. I have a longstanding interest in oral health and in increasing physicians' involvement in oral health, and also in addressing oral health inequities and disparities in our patients, and helping our patients to get access to professional dental care. So I am so fortunate to be here today with Dr. Travis Nelson, who's a clinical associate professor and acting chair of the University of Washington Pediatric Dentistry Department. And he's very graciously agreed to be here to ask some questions that we've received from pediatricians around the state about common questions that come up in their practice or things that they wish they knew more about. So we're just going to get going with some of those questions. And then if you have other questions that we're not addressing today, we hope that you will get in touch with us and share those with us so that we can get you the answers to things that you're interested in learning more about. So let me just say hello to Travis.
Hello, thanks for having me.
Hello. So Dr. Nelson, thank you so much for being here with us today.
My pleasure.
We're going to be talking a little bit about how we can better work together to serve the needs of children, and how we might do that in a better way, and what are the sort of things that pediatricians can do to help improve and optimize the oral health of their patients. So I thought I would just start with a pretty basic question and ask you, what are the important things that pediatricians and other primary care providers can do to promote their patients' oral health?
That's a good question, and I guess from my perspective, I've worked with a number of physician colleagues over the years, and I get you guys are busy. There's not necessarily, we get an hour to focus on that child's oral health, but you may have seconds or minutes because there's so many other things that you need to do. So I guess for me, there's just a couple of things if you could think about from the standpoint of oral health. If the first one would be just making sure the child has a dental home. You think about a medical home, but a dental home is what we consider to be so important for many kids. And the reason for that is that it's a place that they can go regularly to help develop healthy oral habits, to have regular surveillance of their teeth, to receive preventive treatments, and then when needed, restorative type treatments as well. But it's also a place where they can access emergency care. And we know a lot of children, well, especially as they're learning to do things like walk, will fall and bump their teeth. So it's really important that they have a place that they can go for that. And then the other thing that I think is really, really very helpful from the standpoint if physician colleagues can mention it is the importance of a child's diet. I know you're talking about food choices when you're talking about things like obesity prevention and proper nutrition. And it is a natural place to put in some goals for the patient or some messages around oral health. When they hear me talk to them about their teeth, I think they realize, I'm at a dentist's office. They should be talking to me about teeth, but I think they probably perk up when they hear about it from a medical provider, and I think it might even be more impactful. So those are just a couple of things that I think might be helpful.
Great. Well, I think that what you're saying is really important, and I think there's a lot of messages that pediatricians and other primary care providers want to share with patients that have a common message, and that is avoiding too much sweetened beverages, things that have sugar added to them, because we know that in general is not good for promoting overall health, but it's also bad for our teeth. It promotes obesity, and so it's something that we can talk about and have as a common message. So what age do you think, or what age not do you think, or what age do you recommend that children start going to the dentist?
Well, the first teeth will come into the mouth usually by the age of about 6 months. And so we say usually within about 6 months of that, or at age 1. So we say it's kind of easy to remember the age 1 dental visit. And that's generally the time that we recommend children will come in for their first sort of routine well child visit with us.
Well, I know that some people have asked me before when I've made that recommendation, why do I need to go see a dentist when my kid has maybe 2 or 3 or 4 or 5, 6 teeth, and they look fine to me? Why do I need to go see a dentist with just so few teeth in the mouth? And maybe they'll throw in another question, which I know is pretty common. But aren't those baby teeth? Aren't those going to fall out? So what sort of advice would you give to folks if they're hearing those kind of questions?
It's excellent questions. You know, the response that I would have is, in most cases, it will be fine. You know, most of the time children come in and they don't have issues. However, we're able to, with, you know, the bright lights that we have and controlled conditions, we'll look in the child's mouth and we can see early signs of things like the caries process. We can look at abnormal dental development. And if we can catch those things earlier, then it can be much easier to address them, hopefully with preventive mechanisms instead of having to do more aggressive treatment type options. So that would be one primary reason to get children into the dentist early, to be able to do surveillance and preventive treatments. And another reason to establish that care is kind of, as I mentioned, we have more time to focus on that, and we can be delivering really positive oral health messages and hopefully helping that family to develop the positive habits so that we'll keep that child's teeth healthy over the course of the primary dentition and then into adolescence and adulthood.
Great, that's really great. So that made me think of a question, which I know you know the answer to, but
we'll see.
So are there any like red flags that you think pediatricians and primary care providers should be paying attention to that come up, like, for example, in the history, that would make you think, you know, this is a child that I really need to make sure gets to the dentist, and gets to the dentist, you know, by 12 months of age, so that we can make sure that we're doing everything we possibly can to optimize that kid's chance of having healthy teeth and surrounding tissues. So is there anything that you might hear on history, or that we might hear on history, that should make us think, you know, this is a child who is at high risk for getting caries, and I want to make sure that they are getting in early and that we're really focused on prevention?
Great question. Yeah, it from the standpoint of what we can do from, or what you could do, I guess, when you're taking a history and things you might pick up on that might not necessarily be, you know, questions that you would elicit through a review of the child's health. We're looking at risk factors, and this is primarily for caries, right? And risk factors, when you see a family that's toting in, I think of the classic example. I remember of a child who was balanced on one hand by like a bag of chips and the other hand by like a soft drink. If they're coming into your practice looking like that, that means that they're consuming these things frequently throughout the day. So that's really a high risk factor that sometimes you pick up not by asking, but by just seeing. When you look at the parent's mouth, parents who have visible decay, it's very likely those same practices are in place for the child. So when you're seeing things like that, quite important. And then another thing that you might get out of a health history is, if you're looking at a very young child, chances are they probably haven't been to a dentist or had to have a dental rehabilitation procedure, but they might have other siblings or other family members. So if you talk about it from the standpoint of, if perhaps you've seen the 5-year-old first and you noticed that there was steel in their mouth, stainless steel crowns, those were probably not put on that child. You know, they might have been done some time ago, and it may well have been a full mouth rehabilitation. Well, in one of those cases where many teeth were affected, those same practices were in place for the younger child as they were for the older sibling. So looking at sort of the family can be really helpful. Looking at the practices of, as people come into the office, and sort of, you know, if they're drinking sugared beverages, one of the #1 causes of caries for youngsters. And then when you look at health histories, if the families, if for some reason, you know, they said that many other people, adults in their family, had dentures or had their teeth removed, It could be due to, enamel abnormalities or other dental anomalies, but it might also just have been that they had significant caries experience and needed to have that treatment done. Those are a few things that I think of offhand. There are probably many others.
Oh, we really appreciate that. I think it's important that that on the medical side, we're thinking about risk factors for all different kinds of conditions, and we should be thinking about risk factors for dental caries as well. So that's really helpful. That brings me to my next question, which is when should parents and caregivers, when should they start actually brushing the child's teeth? And along those lines, I know a lot of parents tell us, I can't do it, it's too hard, or I don't know how to do it, or my kid fights me, so we just gave up. What sort of advice do you have about starting brushing, continuing brushing, helping a child to feel more comfortable with that?
Mm-hmm. Yeah, so we generally say as soon as you can see teeth, the best way to remove the plaque, the bacteria that cause cavities, is going to be with a toothbrush. Now, for a child who's just 6 months old and has a tooth or two in their mouth, it can be a very quick process. But the sooner they get introduced to the toothbrush, probably the more quickly they'll become accustomed to it, and it can become less of an event. Some kids I know are they're always going to make an issue of toothbrushing. For those youngsters, I think it's just important the family knows it's okay. You're not traumatizing the child. It's really an important thing that the parent is able to get in and brush the teeth. Typically for the really young ones under the age of 3, we're going to recommend just a smear of toothpaste. And then when they get a little bit older, like a 3-year-old would have about the size of a green pea, that amount of toothpaste that goes in. You're able to introduce that, and it touches the enamel, makes it more resistant to acidic attack. And for that reason, children who have their teeth brushed with fluoridated toothpaste have about half the incidence of caries. It gets really pretty dramatic. So that's quite helpful. When you talk about ways to do it, I think one of the things that I see happening a lot when parents are having challenges, I see them in the bathroom and they're standing, face to face with the child and brushing, in like that. And that may work for some parents, some families, but for a lot of them, think about when you go to the dental office, usually the dentist, the dental hygienist are behind, and they're looking kind of down in. And the reason for that is that it's a lot better position. You have more control in that position, and you have a better ability to visualize what you're doing. So if you can adopt that in the home, it means maybe taking brushing outside of the bathroom, going to a bedroom or a couch, the living room, sitting on the ground. There's a number of different ways you can do it, but coming from behind, it allows for a little bit more control of the scenario and better visualization too. So I think that's pretty helpful. The other tip that I have, especially for parents who have young children who really are resistant to allowing them in the mouth, I've taught this to some of my, even some of my dental colleagues, but you take your non-dominant hand and you can put it into the side of the mouth. Sometimes they clamp down, not going to open up. So you can put that in and then open it, push it all the way back, kind of, we call it the retromolar pad behind the last tooth. And then the children will open up and the parent can put their finger on that, and it helps to open the mouth and kind of props them as well. And then you can get a better brushing done. So those are just kind of a few tips positionally, and then thinking about when you start brushing teeth.
Oh, that's super helpful. So when you're talking about the amount of toothpaste to be used depending on the child's age, it sounds like you're talking about using the right amount of fluoride toothpaste. And I know that there's a huge number of questions out there about fluoride and about fluoride toothpaste and when you should start, and aren't you worried that the child's going to swallow too much of it? And then parents will ask, well, I see this toothpaste in the store that says it's safe for swallowing and fluoride free, and it's just really, I think, confusing for clinicians as well as, well, I don't think it's probably confusing for you, but medical clinicians and for families about what is the best thing to do in terms of the actual toothpaste that you're using in young kids.
Well, it is kind of confusing. I think we haven't always been very clear about it. But I would say, if you're working with a family who recognizes that this is a positive intervention, that a step that they're willing to take for their child's oral health, then we can give them good information about that. Some families are just unwilling to use fluoride, and I usually don't fight that battle. There are other messages we can have for those families. But presuming that you're working with a family who's okay with it, then I would say, we're sure that the children are going to swallow the toothpaste. That's been proven. There's good evidence from that when we introduce toothpaste into a child's mouth when they're under the age of 6, they'll swallow half of it. So we know that the amount is important. So that's where those guidelines from the standpoint of the smear and the pee come in. For the very young child, it's okay if they swallow that smear of fluoridated toothpaste. All toothpaste, whether it's adult or child, if it has the American Dental Association or ADA seal on it, or it says anti-cavity, if it has fluoride in it in the United States, it's got about 1,000 part per million fluoride in it. So if it says, it's training toothpaste or fluoride free, it's got 0. And so when we look at that, it's pretty simple. We just go with that smear or that pea-sized amount of fluoride toothpaste, allowing that they're going to swallow half of it. That amount they swallow is safe for them and will actually go in and be incorporated into the permanent teeth, making them more resistant to caries down the line.
Great, well, that's really helpful. So it sounds like what you're saying is that it's actually okay to start using fluoride toothpaste, but you need to make sure you're using the right amount, and that it's okay to even use a very small amount, like you said, a smear, or some people say the rice grain size, even for babies.
That's correct, yeah. If we're asking families to begin brushing as soon as they see teeth, they can begin brushing with that smear, or it's less than a grain of rice, just a very, very tiny little bit.
Sure.
That's the amount of toothpaste that, with the trial size toothpaste that you might get in, the grocery aisle, something like that, you would probably be able to use that from one dental recall visit all the way to the next for the child. So it's really very, very minimal
Sure.
for the youngest age.
And so when parents ask questions like, but my child doesn't know how to spit out, so doesn't that mean I shouldn't be using it? You would say,
no, that you have a normal child. They all swallow some of it, and that's why it's like medicine. That's what I tell people. This is like any type of medicine. We control it, especially in pediatrics. We control it based on the child's weight and age, and that's what we do with toothpaste too. We know some is good, but too much is not. So we want to make sure that we're giving an appropriate dosage for that patient.
Yeah, you're right. That's a good analogy, medicine, right? Like, for example, iron, right? Iron's very good for preventing anemia, but too much iron is toxic. So it's very similar to many things in life and in medicine, where the right amount is important.
Yeah, it always amazes me of all the things that I talk about with regard to pediatric oral health. There's something that seems like it's like the most boring thing that we talk about. It's the oldest thing, but the fluoride and fluoride toothpaste, it comes up over and over and over again. Because perhaps it's, it's a little controversial, but it is really an impactful thing that we can do for our patients too.
Yeah, exactly. Well, great. So that brings me to another question, sort of the opposite scenario. What if you see, let's say, a child who, you were saying routinely you'd expect to see teeth erupt, the lower central incisors erupting at around 6 months. But what if a parent is bringing their child in and expressing concern because their child's getting close to their first birthday and they still haven't had any teeth? Are you worried about that, or what kind of counsel would you give to families about that?
Yeah, we do get questions about that from time to time. It's not a routine thing that we have children get to their first birthday or beyond without any teeth, but it does happen. And it's a good indication to get the child into a dentist. I'd say if they don't have teeth at a year, probably good to go in and have a dental examination. Most typically what we would do is we would have the patient, the baby, the young child, have them sit with the parent, and we would expose a radiograph of the teeth. It seems like, most cases, this is like a therapeutic radiograph because the week later, we'll see teeth on it, and a week later, the teeth come in. We've been waiting so long, they just came in anyway. But on occasion, there's reasons that the child may not have had teeth come in. Not something that I would, really tell the parents they need to be concerned about. But sometimes we'll have a patient who is missing teeth. And an example I can think about that we get from time to time is that we have the teeth that are present are unusually shaped. So they might be kind of conical or pointed. And that might be an indication that the patient has a condition like ectodermal dysplasia. So it's something that we would pick up. The messaging is, let's go to the dentist, let's see if they can take an x-ray. And most likely it's just that they're a little delayed in dental development, which will have nothing to do with their overall development.
Yeah, great. That's really helpful. So one thing that I think pediatricians have a lot of questions about and get questions from families about has to do with sucking habits, let's say, like, so sucking. So we know sucking is how babies get nutrition, right? When they're young, and so it's obviously an essential way to get nutrition. But then babies also are sucking on other things. I know some babies are even sucking on their fingers before they're even born. A lot of parents will have seen that on their prenatal ultrasound. And then, pacifiers are something that frequently comes up, and there's evidence out there that even having a pacifier in some ways can be protective against sudden infant death syndrome. So it becomes sort of an issue like, we know sucking at some point in life is good, and then it seems like at a certain point, thumb sucking or having a pacifier can start to be a little bit more problematic. So what sort of guidance could you give to pediatricians and primary care docs about, our providers, about when they should be worried, or what sort of things they should be asking about or on the lookout for that would suggest that more evaluation is needed?
Sure, great question. Well, I mean, maybe it's good to start with what happens when you have usually it's a thumb or another digit or pacifier. But what you have is you've introduced something into the mouth, and because it's a child who's growing, they're going to grow around that if it's in there often enough. The main signs that we see as dentists, and you will probably pick up too if the patient has a habit that's strong enough or frequent enough, is that you'll see an open bite. So you have to have the mouth, the incisors will sort of be open to accommodate the pacifier or the thumb. You'll see in the back of the mouth, we call it a posterior crossbite. So the maxillary arch is constricted, which is not a positive thing from the standpoint of the child's overall, so a musculoskeletal complex there. And then the last thing, and one of the ones that's actually most concerning initially, is that we see overjet or flaring of the upper incisors. So they're sticking out more. And the reason that can be a problem is because it puts those incisors way out there unsupported. So if and when the child takes a tumble, it's much more likely that they'll have damage to the teeth. So those are things, the consequences of a prolonged and forceful habit. Of course, it's not going to be realistic to get a child who's very young to stop with either a finger or a pacifier habit. But the sort of the party line from the American Academy of Pediatric Dentistry is that we should try to get the habit stopped by about age 3. The reason for that is that if you can stop it, generally you're not going to have those consequences translate into the permanent dentition. Which of course, if you have trauma to the permanent dentition, it can be really catastrophic, and it's a very challenging problem to deal with permanent incisors that have been avulsed or severely damaged. So if you can get it stopped early on, it's much better. But then I think, you do have to take into account the child as a whole and how consequential that is, and also, how significant this habit is. Maybe it's something they're transitioning towards. Oftentimes when they get into, they're spending more time with their peers, it becomes socially not as acceptable. And that might be something that will be sort of a natural transition out of it as well.
So if if you see a family with a child who, you know, let's say is 3.5 and they've been referred by their pediatrician because nothing has really worked to get the child to stop sucking their thumb, are there things that you can do as a pediatric dentist to be helpful in those situations?
Yeah, it depends. I mean, the easier one is when you have something that's you know, not part of the patient, not a thumb or a finger. You know, the pacifiers are much easier because you just have to bite the bullet and get rid of the pacifiers. With the thumb, it's attached. There are different things that people have tried. You know, there's things like nail polish that you can put on that it has kind of a nasty or bitter flavor. I've never found that to be that helpful, although some people swear by it. Usually what I try to do is to work with the patient. 3.5 can be a little bit of a challenge, but if we can use behavioral techniques, I found to be more helpful. And so, you know, when we're talking about reward-based strategies that will be influencing the patient to make those decisions on their own. Down the road, sometimes as patients are older, and if they really want to try to stop a habit, but are just having a challenging time with it, this is, you know, generally around, you know, 6 to 9 years old. We'll sometimes be able to put in orthodontic appliances that are almost like reminder appliances. Those are not intended to be punitive to the patient, but really just as something, once a child's decided they want to have this corrected, it's a more of a reminder type appliance.
Great. Well, that's really good information. Let's move on to an area that I know a lot of pediatricians have questions in, and I don't know that we learned very much about this. But what is bruxism, and is it normal? What's not normal about it? What can we do? What do you guys do about it? I know it can be disturbing to hear as a parent, to hear the teeth grinding, but what else do we need to know about bruxism?
Yeah, bruxism is just grinding, right? So kids are just moving their teeth, and it's very common. I hesitate to say universal, but it's very common. Now the severity of it can really vary quite a bit. You know, you think about it, generally it's something that's just associated with normal growth and development. Sometimes you'll have patients, I mean, an extreme example might be a patient who's had a traumatic brain injury or some other kind of a neurologic condition. Then you would see it to be more significant. And certainly we've seen cases where children have had really extreme cases of bruxism that can be problematic. Speaking more of the typical types of cases, it's oftentimes something that may be just associated with growth and development. And if you think about it, I mean, imagine you had, you know, you'd eaten a raspberry or something. You'd get a seed stuck in your mouth, and it would probably drive you crazy, right? Adults are like this. Children will pouch food for long periods of time, but their mouth is the architecture of their mouth is changing all the time. And I think to some degree they're playing with that. That's a way for them to just sort of find out the way that their mouth is growing and changing. So that may have something to do with it. Sometimes it can be associated with stresses in the child's life as well, just as it can be with adults. But most generally, it's not something that we're too concerned about. And we see kids growing out of it as they sort of exit the primary dentition and move into the mixed and adolescent dentition. As patients get older, we don't do much about it when it's just with the primary teeth. There's not a lot that we can do because the patient is growing and the teeth are changing, and the mouth is, you know, the structures are also growing. But as we get into more of the adolescent dentition, if it's symptomatic, it's associated with muscle soreness or headaches, things like that, then we might consider doing a splint, or some people call it like a night guard. But that is generally the type of route that we would go down for an older patient, adults and adolescents.
Yeah, that's really helpful. Well, I don't know if there's a good answer to my next question, but you know, we take care of you, and I and all pediatricians out there take care of kids that are more medically complex. And oftentimes those are the kids that that you mentioned having a traumatic brain injury, but we know there's other conditions that kids have that it does seem like tooth grinding is something they're doing when they're awake and doing really frequently. And I think parents, worry about, are they doing damage? Is something need to be done about that? And do you have any good way of sort of approaching that with kids who have developmental delays, who have underlying neurologic conditions, who are complex in ways, in many ways? Do you have any advice about that?
Yeah, I mean, generally it's even if when it is pretty extreme. I mean, this is the kind of grinding that you hear outside the bedroom, and it's just, or it's
Right.
happening all the time, and it's hard for people to listen to. Even in some
Yeah.
of those more significant cases, it's not usually that problematic, and we generally monitor it. With patients who have intellectual and developmental disabilities, it can be, it's not generally advised to do things like placing an oral appliance in there.
Yeah.
The concern would be that they would fracture the appliance and then maybe
Sure.
swallow or aspirate. So we generally don't go that route with it. When you have patients who have really severe and profound intellectual disability and maybe very medically compromised, on occasion, in consultation with the medical team, things like injection of Botox into muscles of mastication, things like that have been done, but it's not like that's a fix. It's a
Right.
temporary solution.
Right.
Those are
Okay.
things, a lot of monitoring that we would do. And sometimes, if there is, it's a really important thing to make sure that the patient has had a full and thorough examination, because it could be that the source of the bruxism really has to do with an undiagnosed dental issue. Maybe you have
Yeah.
a patient who has autism, but they have a mouthful of caries. It's not at all uncommon. And once you're able to address that, their patient is out of pain, then that can reduce the bruxism.
That's super helpful. Just to sum up, I think what we've talked about with bruxism is, you'd say it's common. It's common in kids both who are typically developing, as well as kids who have developmental delay or other more medically complex conditions, but that kids that are typically developing tend to outgrow it. And you were saying that happens about the time that they are moving into mixed dentition, when they're erupting their permanent teeth, and there's not a lot that could really be done about it, and probably not a lot of worry that we should be imposing on families about this. But for kids that have other conditions that are have any variety of conditions that we both take care of, but autism spectrum disorder comes up, kids with severe autism spectrum disorder who have significant bruxism, that it's important that they get care, dental care as well, because you're saying that sometimes that can be an indication that there's a problem that needs to be addressed.
You hit it, every single one of the points. Fantastic.
Okay.
You get, Dr. Lewis is now answering this question from now on.
Okay.
That's great. Yeah, perfect.
So then I'm going to move to slightly older kid question, which I think you also know the answer to, even if I didn't ask you it. So when should kids start flossing?
Well, typically we recommend, with floss, it's really something that we do mostly for prevention of periodontal disease. It can be somewhat helpful from the prevention of caries, but really it's the most effective for periodontal disease. And when we recommend flossing is typically when you have contact of the teeth. There's not a huge reason to brush teeth that are have open spaces in between them. So that's something that it varies quite a bit from individual to individual. For sure, by the time the patient has got their 6-year molars by the age of 6, usually much younger than that, probably by 4, they're going to have close contacts. But that big molar that comes in around age 6 has a lot of force and pushes kind of shoves everything together. That's also an age that's a little easier to get compliance from kids, less likely to use digits, lose digits from having them snap down on the parent. So I get, as they're a little bit older, you might get a little bit more compliance with doing that, maybe a little bit more practical recommendation.
Yeah. So I know you've shown some pictures to us before, and we've seen a lot of kids with primary dentition, but maybe we weren't paying super close attention. But those kids normally do have a lot of space between their teeth, right? I mean, that's a normal thing. You shouldn't see like crowded teeth, crowded baby teeth, right?
Well, they come in sort of all shapes and sizes. Some kids just come in, they've got a natural, healthy dentition, but they do have crowding. And what that really means is that they were born with teeth that were larger than their mouth could accommodate. In those cases, if you see crowding in a patient who, crooked teeth in a 4-year-old, they're going to have really significant crowding when they get their mixed and adolescent dentition. That's a case for the orthodontist, almost for sure. When you have patients who have spacing in between, especially their anterior teeth, that's a good sign because we know that the permanent teeth are invariably going to be larger. And so if there's spacing in the primary dentition, then usually we'll have a straighter permanent dentition without intervention. So yeah, it kind of comes in all shapes and sizes, but don't be concerned at all about having a gap between the teeth.
So that brings me to another question. I think people have variable experience if they're not in the dental profession themselves with orthodontists in orthodontia. So if you see a lot of crowding, let's say in a 4-year-old, is that something that pediatricians just say like, oh, yeah, well, I guess when you're a teenager, you can get braces. And I mean, is there anything that, pediatricians should be thinking about if they're seeing a lot of crowding in a very young child? Like, should they be counseling families? So you don't really need to worry about that because that's going to be taken care of when they have braces, when, they're a teenager, or what sort of things would you be thinking about if you saw a lot of crowding?
Well, jokingly, when I see that in young kids, I just tell the parents to start saving because they're going to be visiting the orthodontist later, which is kind of true. It's actually pretty good advice, I think. But there's not much you're going to do for a very young child. As we've spoken about before, establishing a dental home where somebody can be doing regular surveillance and to know the timing for a referral to an orthodontist. There are some kids who really need that early referral, and that might mean by the age of like 7 or so, to correct major issues that could put them at risk for things like trauma or really set them up for worse outcomes down the line. But a lot of kids, they might just need to go to the orthodontist by the time they have all their permanent teeth, which is maybe, let's say, 13 years old. So probably not a lot from the standpoint of the pediatrician, other than making the dental connection, making sure that patient has a dental home.
Yeah, I think that's great because the thing is that, there's only so much, honestly, there's only so much that pediatricians and other primary care providers can really know about oral health. And so just like we make referrals to specialists in other areas as well, it's important to make sure that our kids are receiving the care that they need. And by having children being seen back for regular visits at their dental home, that's an opportunity for you to be following how the teeth are erupting, whether there's crowding, whether or not that's a kid who you think is going to need some sort of earlier intervention, whether that would be extractions or making more space or whatever, that's something that you're going to pick up on, right, as you're seeing that kid for regular visits. So I think that's just another really important reason why it's important to establish that dental home.
Yeah, I think you're right. I mean, one of the things that
I've
found is that you do only have so much time, and so it had to make best use of it. If there are things you can get off your plate by just referring that out, that makes time for you, hopefully, for the kids. There are some patients who really are the very high risk ones that really need to hear from you. There's other ones that are lower risk, and if you can determine that, or you can basically make the referral out and leave it with us to help manage it, that's probably sufficient for those patients. So I think that's a great approach.
If you just sort of for kind of wrapping things up, what if you could sort of talk to like what would be the optimal sort of relationship between sort of a big hard question. How can we better promote communication, collaboration between pediatric dentists and pediatricians in order to make sure our patients as well as populations, I think, are able to get optimal dental care, oral health? What sort of ways can we work together to make that happen?
Well, first thing, we need more webinars. Yeah, no, it's a big question. It's that's a challenge. I think that, you know, the fact that we're just starting these conversations, you know, we've been having these conversations for long periods of time, but making sure that people feel connected, like it's okay to reach out to colleagues. We love to get referrals, we love to get questions as dentists, and I would imagine, you know, it goes both ways, making sure that, you know, the dentist, if we have a procedure plan for a patient, that we want to be able to feel comfortable and like it's an acceptable thing to reach out to you to, you know, let's see that the patient is medically optimized before a procedure. So basically having that dialogue go both ways and feeling, I guess, comfortable with that is important. Feeling like when you refer patients in to a dental provider, I know a number of people who may be listening will have Medicaid clients. And one thing that's been a real concern with regard to those patients is, you know, the pediatrician may refer them to the dentist, but they can't find a provider who will take care of them. So something I'd like people to be aware of is it's called the ABCD, or Access to Baby and Child Dentistry program in Washington State. And so, you know, every county has a coordinator and a champion who will help facilitate referrals for those youngest patients, children who have Medicaid insurance, aged 0 to 6. It's a really great program. It's doubled the rate of children who are getting access to care in our state over the last 20 years. It's very easy to learn more about that. If you just were to do an internet search for ABCD Dental, you would find out all about it. And so that's, you know, an example of a program that's really, really helpful. I think other examples might be through like the physician fluoride varnish program. So being able to do things like that in your office, becoming trained and certified to do something that's really a benefit to your patients and is a billable procedure as well.
Well, yeah, that is really great information. And I think the thing that I want to say about ABCD is, as a pediatrician, you know, this is such a great opportunity for us to take advantage of this resource that's out there, so that we're not having to, you know, do the work to find dentists who are going to accept Medicaid. We know that like you said, within each county, there's dentists that have been specifically trained, right, to take care of very young children through ABCD, and who accept Medicaid, and that by having that information available in your practice so that you can give that to families, that like you were saying, that just takes one more load off of us in terms of doing the work that we need to do to make sure kids are getting good oral health. And I think it's a great thing about our state. And just a shout out to our Cora and the Washington University of Washington School of Dentistry, and the county level dental societies, all those folks who made that possible, who really have made Washington State really a trailblazer in that way, with making sure that kids can access dental care. So I really appreciate you bringing that up, and I really appreciate you being with us here today and answering our questions. And like you said, hopefully there'll be more chances for collaboration and
yeah, this was a lot of fun. Great questions. Hopefully helpful. Hopefully I didn't give too many wrong answers today.
Oh no, you were awesome. Yeah, very good that you were able to kind of handle whatever I threw at you. So that was great. So thanks again for being here, and we really appreciate it.
Awesome. Thank you very much.